Each year, 20,000 patients have been diagnosed with brain tumors that originate in the brain. And over 200,000 patients will be diagnosed with tumors that have spread from other parts of the body. Today on Medical Update, advances in treating brain tumors. Stay with us. Joining us today is Dr. Michael Schulder. He is the director of the Brain Tumor Institute, and he's the vice chairman for the Department of Neurosurgery. Welcome.
Thank you.
30 years ago, Dr. Schulder, a brain tumor was decidedly something very difficult to deal with and almost a hopeless matter. How has that changed in the past decades?
Well, overall it's changed because getting the diagnosis of brain tumor nowadays no longer has to mean a death sentence for a patient. And patients and families should understand that many new innovations in surgery, radiation therapy, medication, and new therapies for patients with brain tumors have changed the prognosis drastically and have allowed many patients to be cured and to live long and healthy lives after the diagnosis.
Now, these patients with brain tumors come to you. They're referred to you by doctors from all over the area. They come to you with a definition or a diagnosis that you have a brain tumor.
Yes.
In the past, this has meant treatment that was drastic. I mean, you really had to go in and try to get the tumors out. But that is changing. Take us through some of the things that we might expect today when a patient has this kind of a designation. I understand there were two types of tumors.
Yes.
The primary, which is in the brain, and the one that spreads to the brain.
Right, and those are sometimes called metastatic tumors.
The ones that spread to the brain.
Right.
Now, do you treat them the same way?
Possibly.
Okay. Take us through this.
Okay. When someone can be cured with surgery of a brain tumor, we usually recommend that as the first treatment of choice. But surgery today is not what it was in the past. It's much more precise thanks to a variety of technological innovations, one of which I'd like to discuss today, and that is the use of intraoperative MRI, the ability to take MRI scans during the surgery itself, so we don't get any surprises on scans that are done, let's say, the day or the week after the surgery. And we can know if there is more tumor left behind. We can remove it at the same time during the surgery, and we can also avoid doing unnecessarily aggressive surgery, again, by doing an MRI scan during the surgery itself.
Now, I'm a little confused. This is the actual surgery, and later we're going to be discussing what you call stereotactic surgery. But
right.
To me, cutting is cutting, but there's a difference. Stereotactic surgery is not cutting.
Well, stereotactic radiosurgery employs radiation beams focused on a small area to give a very potent, a very high dose of radiation to that sharply defined area, such that a tumor can be destroyed or prevented from growing with essentially no radiation given to the surrounding brain.
Now, you make the decision of what is best for the patient.
Yes.
The surgery that you're about to describe, the MRI type, versus because you hear a lot of, you don't have to go through surgery, we got stereotactic. I mean, it's a little confusing.
It's confusing to doctors as well. There aren't a lot of people who have the expertise to deliver both surgery and radiosurgery and understand the advantages and limitations of either technique to recommend the ideal treatment plan for a patient.
All right, take us through both of them. Begin first with the surgery, the MRI type surgery.
Okay. When someone is going to have surgery for a brain tumor, there are a couple of areas of uncertainty, and intraoperative MRI is a way to eliminate those uncertainties. One is to know exactly where to approach the tumor through the scalp and then through the skull. and to limit any unnecessary exposure of the brain during surgery. By using this method, we can devise a very precise path to the tumor and have the smallest possible incision, opening of the skull, and the smallest possible exposure of the brain. The other uncertainty during surgery is, well, did we get the whole tumor out or not? And until this technique became available, the best we could do was rely on our judgment, which is gained through experience. And that is reliable some of the time, but not all of the time.
Yeah, but when you say MRI, most of us are concerned with you get into a machine and you're rolled in, but this is not the same kind. You're still using the same technique of examining, but how is it different?
It's an amazing technological innovation which allows us to bring MRI into an operating room.
While you're operating?
Yes, because most people think, as you said, of MRI as a very large, complicated, noisy machine. It occupies the whole of a very big room, and it takes 45 minutes, and you have to lie there completely still. But with this method, we can take images during the surgery itself with essentially no disruption to the normal surgical routine.
Yeah, did you bring some video maybe you could show us?
I could show you some images of the system.
Let's see it. Let's see what it looks like.
Okay. This shows our intraoperative MRI unit being wheeled into space.
It's portable.
Yes.
Not portable, but I mean it's
mobile. Yes.
Yeah.
And this shows how it can be positioned just by even one person manipulating it, and he's now going to bring it to position under the operating room table, and everything else in this operating room is what we use in a regular surgery. This MRI is so compact that the magnetic field it generates is concentrated only around the patient, so we can proceed to do surgery in a standard fashion. Now this of course shows the MRI, as we say, parked under the operating room table. When we want to take an image, we use this control unit, and by pressing a couple of buttons, we bring the magnet into position, and we get our scan. When we're done with the scan, we lower the magnet below the table, and we proceed with surgery in the usual fashion.
But, you know, when you go in MRIs, they remove all your, anything metallic. How do you use tools when you're using MRI?
When the magnet is below the table, the magnetic field does not reach the level of the patient's head. So we can use our usual dissectors and fine instruments made of any metal, including steel, that would otherwise be attracted to the magnet, but because the magnet is not around the patient's head, we can do the surgery in that usual fashion.
Show us some of the visuals that you see with this, that takes you through this system. Now, this is what?
Here's an example of scans that we obtained on a patient, a young man who had what appeared to be a benign primary brain tumor. That is, the tumor arose within the brain itself.
Now, where do we see this up here?
These are scans obtained over time during the surgery. So on the left, looking from top to bottom, we can see an image of the patient obtained in the OR itself just before the surgery began. This white area here, or I should say light gray area, is the tumor.
Okay.
These other white areas, well, those are normal areas that contain fluid that are present all the time in someone's brain. So we have identified the tumor on the preoperative scan. Then, during the surgery, when we thought that all the tumor was removed, we repeat the scan in just that same way that I showed by raising the magnet up. And to my surprise, actually, the scan showed that there's still some of this light gray area here and under these purple marks as well, and I'll explain what those purple marks are in a second. And these light gray areas represent that there is still some tumor remaining, and it's very hard to identify with the naked eye or even with an operating microscope. Only the image will show you that the tumor is still there. And how much better to know that at the time of the surgery than being surprised on a scan done after the surgery, a day or a week later. We then used this special tool which helps us to, as we say, navigate down to this area, and that's what these purple or pink marks represent. We then use a special instrument that is able to work inside the MRI magnet to remove the rest of the tumor. And on this last scan on the right, again looking from top to bottom, we can confirm that these abnormal areas have been removed and that the entire tumor has been resected.
Now, how do you make this decision to do this with this particular technique?
Anytime someone who's having an elective surgery for brain tumor removal, my first choice is to use an intraoperative MRI. There are almost no exceptions to its being able to be used. If someone has a pacemaker, or if someone is unusually large and they may not fit inside the magnet, then that might rule out the use of the MRI. But that's true of almost none of our patients.
Now, in addition to this do you use this same technology, this intraoperative MRI, with other surgical steps that you do?
I have an example I could show you.
All right.
The previous patient had a tumor that arose inside the brain itself. These are scans of somebody who had a tumor arising from the pituitary gland. And the pituitary gland is a normal gland that sits just below the brain. And it sits roughly below the area where the optic nerves, the nerves that bring vision back from the eyes to the brain, are traveling. So when tumors get to be very large, they can impair vision. This is the scan obtained before surgery, and all these images are from one scan. Normally the pituitary gland would be a little white, sort of lozenge-shaped structure down here. Mm-hmm. And you could see the optic nerves here. In this case, this whole white area, that's the tumor. The optic nerves are not visible because they are compressed so severely by the tumor in this patient's case. And this person had begun to lose vision and was at risk for going blind if this tumor was not treated.
What was the result?
Well, this is an image of us beginning what we call an endoscopic approach to the tumor in the operating room. This is going only through the nose. There's no incision or cutting needed on the scalp or the skull or even inside the nose. No incision at all.
So in this case, you used the same movable MRI to vision step by step as you went along until you succeeded.
Yes, and here's the MRI scan below the level of the table during the surgery.
We're going to take a break now and come back, and I'd like you to continue on this and compare this with the next technique that you're about to describe, and that's the stereotactic, which is a little complicated, but I'm sure you can make it simpler for us to understand. So stay with us, and we'll be right back.
It may seem intimidating, but really, it's one of the easiest things you can ever do.
I've been practicing.
Good. You're gonna need it.
Help America's youth. Be a friend. Be a mentor. Just be there.
Go to bigbrothersbigsisters.org.
When you fill someone's life with hope, you wind up adding a little more to your own. Help America's youth. Be a friend. Be a mentor. Just be there.
Go to bigbrothersbigsisters.org.
Dr. Michael Schulder is the director of the Brain Tumor Institute and vice chairman for the Department of Neurosurgery. And you've been explaining to us how you use the intraoperative MRI, which is absolutely fascinating. Give us another example and then take us over into the stereotactic radiosurgery type of procedures, okay?
Sure.
All right.
These are images taken over time during surgery of the patient I had begun to show who had the large pituitary tumor. So on the left, from top to bottom, you see the tumor in white. That's what it looks like normally on an MRI before the surgery. When I thought that most, if not all of the tumor was removed, I repeated the scan. And to my surprise, most of the tumor was still present. By taking another look with an endoscope and an operating microscope, I was able to find where the rest of the tumor could be removed.
In other words, you went right into it with a real tool to look at.
Oh, yes.
The endoscope.
Yes.
Okay.
And then we were able to continue and complete the tumor removal. And this last scan done here, about 3 hours after the surgery started, is done after an injection of what we call contrast. And an MRI with contrast injection is the best tool we have to look at pituitary tumors. And this confirms, if you compare this scan to this, that the tumor has been completely removed, and we can now see the optic nerves. So the optic nerves, the nerves that bring vision back from the eyes to the brain, are no longer under any compression.
And the vision was restored.
Yes.
It's an amazing difference between 30 years, just 3 decades, and what you can do today. The prior operation, which you would have had to do on this patient, would have been gross. I mean,
yes.
I doubt whether you could have succeeded anywhere in these cases, which in those days was generally as best as you could do. But now this new technique, take us into that, the radio frequency approach.
Or stereotactic radiosurgery.
Right.
Well, this is a very exciting way to treat patients with brain tumors with a minimally invasive technique.
Specific brain tumor, all kinds of brain tumors?
Pretty much, that's right. Even benign tumors, malignant tumors, primary tumors that arise from within the brain, metastatic tumors, that is tumors that have spread from somewhere else in the body. These all can be treated with stereotactic radiosurgery.
It's that precise?
Yes.
Okay, take us through this.
Well, this method was defined by a neurosurgeon in Sweden who invented it years ago. He called it closed skull destruction of a precisely defined intracranial target using ionizing radiation. In other words, we focus a high dose of radiation on a small target. The result is that very little radiation is given to the normal brain, essentially none. As opposed to radiation therapy that people may know about going on for weeks, this is a one-time, non-invasive treatment, which does not cause hair loss or other similar effects, other similar side effects of standard radiation therapy.
Well, the standard radiation is gross. I mean, whole areas. You're
Yes.
talking about tiny pinpoints.
Yes. And standard radiation therapy for sure still has its role. I would not say that it does
Right.
not. It definitely has its role, but there are many patients who can be treated in addition to radiation therapy with radiosurgery or with radiosurgery instead.
Okay.
So here's an example of somebody. This patient had a benign tumor called an acoustic neuroma. This often causes hearing loss, and although it is a benign tumor, as it grows, it can be progressively disabling and even life-threatening.
Now, where is it on this picture?
It's this white ball and that little tail over here. And this is looking down at the brain, so this would be on the way the MRIs are done, the left side of someone's brain, and this tumor is pressing on a critical area called the brainstem. This tumor enlarges, then the patient will start to have trouble walking and eventually could be blinded and die as a result of this tumor.
And what did you do?
Well, this patient preferred to have stereotactic radiosurgery rather than open surgery. And I discussed that with her, knowing that the risks of open surgery for a tumor this size can be prohibitive. There is a substantial risk of facial weakness or of permanent difficulty walking, loss of balance. There are even life-threatening possible complications from the surgery. So I'd like to show an example of the plan of the stereotactic radiosurgery in her case, because this is done by computer modeling. This is a three-dimensional model of the tumor. In here, these are the eyes, the optic nerves, and the brainstem. The tumor is encased here in the radiation field. These are the different beams that will be given to focus on the tumor. Where each of these beams pass through the brain, almost no radiation can be detected. But where the beams meet, a very powerful dose of radiation is given. And what these two-dimensional images show is how quickly the radiation falls off, so that once we get within millimeters of the tumor, the amount of radiation to the brain is almost undetectable. And there's certainly none given to the scalp.
So you're targeting precisely what area are you targeting? How much of an area is that?
It's a tiny area. It measures maybe 2 centimeters in its maximum length, 20 millimeters, less than an inch.
And you continue to go around, and this does not harm the normal tissue?
That's right.
Is it selective in that only cancer cells are killed, or is it just the cells no matter where you point it?
That's a great question, because it's true that the same dose given to the brain will be much less potent than given to the tumor. In other words, the likelihood of side effects to the brain from the same dose we give to the tumor is very low, even though it's enough to stop the tumor in its tracks.
And how successful do you find this?
This technique for this type of tumor and for most benign tumors in the brain will stop the tumor from growing at least 95% of the time. And what happens is what you see here. This is an MRI scan done 6 months after the treatment. There is less pressure on the brain, or that area called the brainstem. The center of the tumor has turned dark, and this is what the tumor looks like on its way to shrinking down to a small sort of marble, and it will stay that way for the rest of the patient's life.
How is the patient affected after this? Is there any side effect? Is there any...
If too high a dose is delivered, or if the radiation is not delivered precisely, there can be side effects. So this has to be done with great care and great expertise.
Once it's done, that tumor is removed, it will not come back?
That's right.
Or is this the case for all tumors, or is it just in this particular instance?
Well, it works particularly well for patients with benign tumors. And this is another example of somebody, or rather, this is just an image showing how someone is treated during the surgery. They're in a room containing what's called a linear accelerator, and that's the most common device we have to treat someone with a brain tumor.
Now, is that machine sending separate beams, or are you moving the machine? How does that work? How do you target it?
As the machine moves, the radiation is delivered, but very little radiation is given on its way towards the tumor. If you put a Geiger counter there, you probably wouldn't pick it up.
Really?
Yes.
But when you get all the beams coming together at that one thing, it's like, how, in lay terms, what would it be like? It's hard to imagine.
It adds up. Actually, at that level, the mathematics are not terribly complicated.
I guess in a way it's like holding a magnifying glass to the sun and
That's
having
right.
it all concentrated and burning that one specific tiny spot.
That is a perfect analogy. That is correct.
Well, that's why I get the big bucks. No, but anyway, take us, now, you've got different, is this for other forms of cancer and other tumors in the brain?
Yes. Now, this patient had what was called a meningioma, and she had double vision because this tumor, pretty small at this point, is sitting right in front of the brainstem.
What is that little white area?
Little white area. It's affecting a nerve that controls movement of the eye. And because her eye movements were impaired, she had double vision. Now again, if this tumor would be allowed to grow, it would reach a disabling size, probably in not too much time, within a year or two, and ultimately be life-threatening. Surgical removal of this kind of tumor is very hazardous and very difficult in the most experienced hands to achieve without complications.
In the past, it would have been literally impossible to do this.
That's right, and someone like this probably would have had surgery and most likely would have had some pretty bad complications.
Blind?
Perhaps.
Other
difficulty walking, poor coordination, perhaps paralysis on the right side of her body.
All right, the patient now has this. What's the day after? What's it like? Does that patient get up and go home?
She goes home the same day.
Oh, the same day?
This is an outpatient treatment. You come in your street clothes. The treatment is done. The whole process takes about 4 hours. The treatment itself is about 30 to 40 minutes. You go home. If you wanted to go to work the same day, you could, although I always advise patients to take it.
For a brain tumor?
Yes. Yes. It still amazes me, even after years and doing this many, many hundreds of times.
Wow.
I still get a charge out of it.
So you must. Now, so this is for what's called meningiomas. Now,
Yes.
what, are there other techniques, other kinds of approaches you use with this facility?
Well, I'd like to say that even for patients with certain malignant tumors, the radiosurgery can be applied. This patient had a malignant melanoma arising from an area called the skull base, sort of behind and below her eye.
And that's what? Show it to us.
This is an image of her brain, which shows a small metastatic tumor. This is a melanoma that's spread to her brain.
That little white spot?
Right, it's like a little marble, less than an inch wide.
Okay, and what did you do in this case?
Well, together with my colleagues in head and neck surgery, we wanted to treat her aggressively because she was young and she was in good condition, working person. And we said, well, we don't want to subject you to the complicated surgery of removing the place where the tumor arose unless we get rid of the brain tumor first. And we thought the best way to do that would be with stereotactic radiosurgery. And this is what the treatment plan in her case looked like. This is a model of her eyes and optic nerves and the brainstem and the tumor up here. Here are the beams, and they're intersecting at the tumor. Because this tumor is small and in a relatively safe area of the brain, we can give a very high dose of that small area. And 6 weeks later, if you look at this CAT scan, you see that the tumor is gone. So in this case, we didn't just stop it from growing, we basically melted it away.
Well, you say melted it away. What happens to the stuff that's left there? Is it vaporized? I mean, the residue?
Not right away, but the tumor cells die.
It's
and
absorbed?
The brain absorbs it. Yes, just like it was a small bruise.
And this whole procedure takes?
The radiosurgical treatment, in her case, took about 30 minutes.
That's remarkable. Now, you also have something that you plan to do at the Institute on using electrical fields. I mean, this is science fiction kind of stuff. What is that?
I would say that it is. In about a month, we hope to open this trial. And the reason we are exploring trials like this, among others, is that many patients, especially those with primary brain tumors, the tumors known as gliomas, cannot be cured with surgery alone, or even with surgery, radiation, or even adding chemotherapy. They may have the tumor removed, they may be in good condition for a number of years, but over time the tumors will tend to grow back. And
so what do you do there? What's this new experiment?
Well, this is a very exciting trial because it has some preliminary results that show promising destruction of tumor and even shrinkage of tumor in a variety of patients.
What's it called?
It's called the NovaCure trial, and it's applying tumor therapeutic fields, as they're called, to the patient. Just using electricity.
An electric field around the head?
Electric field is completely non-invasive. It uses electrodes that are applied to someone's scalp. They can walk around with it, and over 6 weeks have the treatments.
You got a picture, I think, of one of those. Let's look at it.
Okay. This is a patient who's going about his daily activity.
And he's being treated.
He's eating breakfast, he's playing with his kids, he's doing some reading, and he's working on his computer while having these electrodes applied to his scalp.
In other words, what he's getting is an electrical field that one hopes the study will show disrupts and prevents tumors from coming back.
Somehow it appears both in the laboratory and in clinical evaluation to stop tumors from dividing.
Wow.
And killing them.
That's super science. But it's remarkable how things have changed just in the last 10, 15, 20 years. It's just astonishing. Thank you so much for joining us here today. This has been most enlightening, and I'm sure we've had an audience that's been ripping their chairs while they watch.
Thank you.
Thank you for joining us, and we'll see you later.